1 p.m. So let's see, did I press on this correctly? Okay, great. Good afternoon, everyone. It is now 1 p.m., Friday, October 23, and the class is MED140, Basic Clinical Procedures, 8AAX. This is now week 2. So what is due today? Your discussion, as per with proper APA format, and those of you who did answer me already put comments, and look at this video here for 7th edition. And there's also I think I put a another library video here. There's another video here from our librarian, Ms. Zoe Page. So please look at that, because the first week was on me, because I didn't really train anybody yet, or if somebody didn't have my class before. We're doing 7th edition APA format, and your citation has to be your submission has to be at least 200 words. And some of you are already starting to answer other people. When you answer someone's post, don't just put, "Hey, I like your post. It was pretty cool." Okay, fine. If you like someone's post, then you I did see that students typically write why, but find some citation, find some evidence that will further support the original author. All right, it's not the mutual adoration society where you get credit for saying, "Hey, I like your post. Hey, I like your shoes." It's, so what? Why exactly? Or add to the, and that's what a discussion is. You add to the conversation. Okay, and that's what a real academic discussion is. But for the discussion one, if you answered somebody, that's really great. And but for the week 2, for this discussion 2, kindly uh, expand and try to write a little better. So what's due today? Homework 1, I added a quiz because typically I give the quiz if we were an on the ground class, but I added a quiz this morning. So make sure to look at this quiz. No real time frame on this quiz since I added it late. So I'll give everybody a couple of weeks, but right after you did chapter 6 and chapter 9, just do it right there. So and to reiterate, the way you garner attendance is 2 ways. You either show up for this class, and that's one way. And of course, you try to do, let's say you couldn't show up for my class, shoot me an email so I can at least give you a little assignment, something short and sweet that I can allow you credit for. Because remember, there's credit for the lesson, and the lesson is the actual attendance or whatever little thing I can have you do for your lesson, because I believe not all the class is available at 1 p.m. on Fridays. That's why we're recording this session. So again, to reiterate, lessons, if you missed it today, please get to me so I can give you something short and sweet, something you could do over the weekend so that I can give you a lesson grade. Homework 1 is due today, discussion 1 is due today, and so later on this afternoon, I don't see anything, it's just zeros. And then for every day after, it's 10%. Okay? So what's for this week? Okay, we're doing, and for some of you who have me for the earlier class, MED 260, it's a lot of these things are redundancies between these 2 classes. So you're going to see the same things for the first couple of sets of chapters. So this last week, if you were in the morning class, we were talking about history taking. So this week I'm gonna reiterate it and do the same here. But for this week, I'm also going to attach vital signs and measurements, and of course, hand washing. Make sure to watch the hand washing video as well. I also have an old chapter 36 video of history taking that I did a couple of years ago, just as a as an extra. But if you're looking at the announcements and today's lecture, it's relatively the same. So let's jump right in. And for those of you who already had the history taking portion of it last week in the MED260 class, this will be a nice review. And it's as you could see, it's just an outline, and it's the same exact things that we were talking about before. So let's go right into the textbook. There you go, red shelf. Go in here. And again, as a public service announcement and a little extra reminder, the notes, I'm trying to catch up on my notes, but the notes, the page numbers don't match because they're from an earlier version of this textbook. So I'm going to click on this, then get into my table of contents right here, and I'm going to go to chapter 36. And right down here, no, that's too far. 51, clinical practices. 36, patient interview and history. Okay. So patient, we all know that we already talked about subjective, objective, assessment, and plan. The patient interview and history is the subjective portion, and it deals everything about the subject, which is our patient. Now, our patient, when they talk to us, sometimes they're not, when we tell our stories, sometimes it's not entirely accurate. So any subjective data, which is the patient history, you have to take it with a grain of salt, because I don't know this guy from Adam. He could just be messing with me. He could have mental disease or defect, or he could just be a jerk and just wants to mess with me, or maybe he's older, can't remember as well. There's a whole bunch of factors that deal with the validity of the subjective data or the patient interview. And even if we, let's say, for example, I was discussing this morning at this morning's lecture, that even if it's obvious that the patient is higher than a kite, you can't write down in the chart, oh, patient is high as fudge. You have to write down what you see in an objective manner, even though what you're looking at is highly subjective and it's open to the interpretation. But let's look at this case. So Mr. Smith, male patient, over 70, probably retired. And remember, these cases, they leave out employment, which when you're really presenting, you always talk about age and employment when you're doing a case. He has a previous medical history of mild type 2 diabetes. And when they say mild, it's most likely controlled with either medications or diet. He called in for an appointment. He states that he is, quote, feeling very anxious and fatigued and having difficulty eating and sleeping. Now, when we chart this thing, I can't say, oh, patient has anxiety disorder, or patient is has continued malaise. That's MALAISE. Those are diagnoses, right? Or difficulty eating, which is dysphagia, and difficulty sleeping, which is insomnia. I can't write those words down. I have to write, since it's the subject, I have to write my subject's words. So that's what the chief complaint is, and that's part of our subjective, that's part of the history. That's actually the first thing. Now it goes into the history of present illness. During the patient interview, he states that he wakes up in the middle of the night almost nightly. He also has many nights when he can't even fall asleep. In addition, he has lost about 8 pounds in the last month, and his symptoms started 6 months prior. So when we're reporting this, we always do in reverse chronological order. So we always say things like, Mr. Smith, a retired businessman, Caucasian, age 70, 6 months prior to consultation, the patient experienced blah, 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 right? And it works. And notice that we didn't talk about anything else other than the things that are currently bothering him. We didn't talk about his diabetes. We didn't talk about other things. We only talked about the events related and leading up to his chief complaint and what prompted either admission or consultation. So we always say things like, excuse me, 6 months PTC, which is prior to consultation, or if he's being admitted today, 6 months PTA prior to admission. Okay, so what did we do? His management, we scheduled a sleep study scheduled with Metro Sleep Specialist. We probably also might send him to psychiatry and or neurology, because there could be other things going on because he has an advanced age, right? And the current physician that was seeing Mr. Smith was Dr. Buckwalter. NKA is no known allergies. Does that mean that my patient doesn't have allergies? No, it means what? No known allergies, no known reported, or no known that we can elucidate from his previous physicians or from the patient himself. So you could see how there's a million and two things that a clinician would be thinking about. And right now we're also thinking about he could be going through some depression because that's his son, you know, and that's it's a hard thing for those of you in the audience who have children. It's a hard thing when they get sick, and even a harder thing when they die. So this will this can affect you significantly. And we talked about in anatomy and physiology how your emotions can directly relate to your immune system, directly relate to your brain chemistry. But 6 months, having these relatively mild symptoms such as these for 6 months, we usually look at bereavement for a year. And bereavement's going to look a lot like major depressive disorder, but with the history of, you know, a significant loss of a family member. And with adult males, the big loss is usually spouse. A lot of adult males go south health-wise and mentally after the loss of a spouse or after a divorce, statistically. So the patient interview and history. Know your patient's rights and responsibilities. Those are all those paperwork that's in the beginning of you know, the physical chart, and those are the paperwork that when you first come, the first time you come into the doctor's office, that's that pink and yellow and all those multicolored forms that you usually fill out in the beginning. And nowadays, a lot of this stuff is now done electronically. That's another thing that you need to now navigate in the you know, the modern world, because many of the appointments are now virtual. So many of these patients' rights, responsibility, and privacy forms are now also electronic. So if Mr. Smith, let's say, for example, he's not too computer savvy, you might have to help him out over the phone. And if any of you have ever helped out your parents who are not technically savvy over the phone on trying to reset their password and things of that matter, oh, that's an adventure. I just do everything for my mother. She refuses to learn any of that. But again, it's part of it's part of the obstacles that we have regarding patient communication, and also dealing with electronic medical records and the new normal, if I want to use an already hackneyed phrase, that we're doing now because of the quarantine. Now, communicating with professionalism, okay? Using effective listening. Many times, because you let your patient, even if you don't have that much time, you let them ramble a little bit. You let them work stuff out verbally. Look also aware for non-verbal cues and body language. This morning I had a lecture on physical examination, and I was talking about how when the doctor touches you, many times I'm not looking at where I'm touching you. I'm looking at your face, because if there's pain, you're gonna and you know, you're a tough guy or tough gal, and you don't want to embarrass yourself on where the pain is. Many patients, they try to hold it in, but you can't hide the small micro reactions that you have, and that's called grimacing. When your patient makes a little face when you're examining them, and that prompts you as the future clinician to go look at that. And is somebody off mute because there's like heavy breathing, or maybe that's me? um, Broad knowledge base. The best way that regarding broad knowledge base is right now you're training, and also if you don't know something, you read the chart ahead of time, and you don't know something, you have Google nowadays, so you get on it, and you at least learn something real quick before you get in the screen. Actually, at Inova, there's multiple screens for patient advocates, because they have access to the chart. So part of the protocol before the advocate starts talking to you about your health and your life and all that stuff, in theory, they're supposed to take a couple of minutes. Well, not in theory, in practice as well. They take a couple of minutes to analyze their chart, look at the chart, learn a little bit about their situation, so that when they talk to the patient, they're kind of informed, and it's nice, instead of, you know, starting from scratch. Always look at the general picture. Like, for example, we were looking at Mr. Smith. At first it looks like what? Maybe he has a heart problem, has some anxiety, and then he can't sleep, and then we could just chalk it up for being, you know, to being old, but you can't. When we look at the larger picture, it's going to start to look like bereavement or major depressive disorder, because now we see, if we find out during the interview that he was close with his son, or his son was relatively young when he died, or even when his son died traumatically. That's also a rough thing to deal with, knowing that your child suffered. That's a hard thing, and like I said, as a parent, I go through that, and you as well, as those of you in the audience who are parents, you guys know how that feels. Now, effective listening. One way that we can also effectively listen is restate what your patient's trying to say to you. That's also known as mirroring. Like, for example, if your patient's talking and you want to get clarity, you just restate what they said, and you ask them, is that how it went? And then every once in a while you go, no, that's not what I meant. And then you go, so what did you do? What did you mean? So that restatement, mirroring, clarification, they're all variations on a theme regarding effective listening. Okay. Um, I already mentioned, do your research, plan to interview. And what do I mean by plan to interview? Know what you want to say, what you want to ask. Have your forms already there. Be ready. And garner permission. So this is how you do it. You always have to identify yourself, right? Identify rationale of why I'm talking to you, and also garner permission. So it would sound something like this. Hi, good afternoon. My name is Nelson. I'm your medical assistant this afternoon. Dr. Cassidy wanted me to ask you a couple of questions before we begin. He's with another patient, but he's going to be in here soon. So is it okay if I talk to you? Do you see how we eased ourselves into that? Because I need to make you feel at ease quickly, because you don't know, in the next 20 minutes, I could be sticking a needle in your eye. I'm exaggerating, but I could be doing phlebotomy, or we could be doing something as horrific as a digital rectal exam. So I have to garner trust with you quickly. And of course, interview in private without interruptions. In the beginning, you're going to want to write everything down, but a good interviewer would listen and then write stuff down. I had a medical assistant. She kind of got in trouble a year back, because She made no eye contact with the person she was interviewing because she was so hell-bent on getting the story and getting the history straight that she didn't pick her head up off of the paper. Or and then the patient was like, "Can you please look at me?" And she goes, "No, I'm busy taking," and she said, quote, "No, I'm busy writing down these important things." So the patient took offense to it, and then all this hullabaloo, right? But what if she did what? Just stop and listen and get the big picture and then write them down. Be careful when you're dealing with sensitive topics. For example, when you talk about social history deals with all the really cool things that you would do at a party, like smoke, drink, do drugs, have sex, and what kinds of sexual things that the patient does. That's sensitive, and that's hard to ask. And again, and look at the person you're speaking to, and then make sure to get to them the rationale of why you're doing this, because it all relates to the doctor helping you out. Okay. And try to get the big picture, because many times when the doctor comes in, they also want to be briefed right before they go in the room. How many times did my doctor, when I was a medical assistant, Nelson, what do we got here? And then I could do what? And this is what it would sound like. So let's go back to Mr. Smith, and I'm going to pretend that Dr. Buckwalter asked me about Mr. Smith. Hey Nelson, what's going on with that bald guy in room 5? Well, doctor, we have a 70-year-old retiree male Caucasian with a past medical history of type 2 diabetes, who came in with the chief complaint of feeling anxious, fatigue, difficulty eating and sleeping. Symptoms started 6 months prior to consultation. He claims 8 pounds weight loss within that time, and multiple evenings where he doesn't even fall asleep. Also notable, at 6 months prior to consultation, his son died of an auto accident. That is how a professional, and do you see how long it took me to do that? Not even 30 seconds. And then it gives the big picture to the physician, and that skill set takes a while to learn. Okay, but that's an example of how you present, and you always start with the patient's name, age, occupation, and what the chief complaint was. Then you roll right in the history of present illness in reverse chronological order. Alrighty, let's now go to here on page 469. There's some really neat ways to effective methods of interview. Always ask open questions, right? Like, how do you feel about that? And try to avoid yes and no questions, which are closed-ended questions. And I'll show you in a minute the exception to when we have yes and no questions. Have hypothetical questions, like broad, like, hey, when do you have chest pain? It goes, if you had chest pain right now, how would it feel? Can you tell me about that? You see how I keep it open and it's not a yes and no? Mirroring, verbalizing, clarification, these are all, like, again, they're relatively the same thing. What you're trying to do is restating the words that you have your patient, so that there's clarity, so that you know exactly what the patient means. Another neat thing that you could do is have your patient reflect on things, like, for example, Mr. Smith, your symptoms started 6 months ago, and you told me 6 months ago your son died. Do you think that's related? You're sleeping and all that. Do you think that's related to maybe some grieving process with you and your son regarding your son? So it makes him to reflect on it. And then if you hear, nah, I hated that SOB, but my job, or I miss my job, then you can't assume, you get to the crux of the matter. You don't ask leading questions. Leading questions are like, what was the example I gave in the other class? The example I gave in the other class was, in the late 90s, early 2000s, the American Psychological Association started noticing that a whole bunch of people were being diagnosed with, not PTSD, but with issues with like with daddy and mommy issues with thinking that their patients were molested or physically abused by their parents. Now, they looked into it, of course, as professionals that they are, and then they found that many clinical psychologists were asking leading questions, things like, um, for example, "Hey Nelson, do you?" He goes, "Do you think? Can you think of a time where your father touched you inappropriately?" And I would, that's already putting something in my head, and then I'll start. I never thought of that before, but now that I'm thinking about it, he did touch me and then then you're leading down a path that you're leading the patient towards something that's not real. And that's the issue with memory. Memory is also, it's highly subjective. Another example that I used in my other lecture is, like, you ask me right now, "Oh, how was high school?" High school was awesome. But then when I really think about it, no, it wasn't. I was broke. I'm working two jobs. I was always I was always getting into a lot of physical fights, and I don't know. When I really analyze it, it wasn't a fun time. But if you ask me, my feelings or my subjective data is telling me what? Oh, it was a blast. I loved high school, right? But in reality, um, the memory is tainted with emotion, and that's also another obstacle that we have to overcome when we're interviewing our patients. Do not challenge your patient, okay? Especially if they're psychotic. Psychotic patients, right? They believe what they believe. For example, if my patient believes the dragons are living in the ceiling, don't say to your patient, "There's no dragons here. I don't see anything." They're gonna get very defensive, and they may even get violent. Challenge therapy is made only for professionals, and professionals who are behind plexiglass and have orderlies watching the patient just in case they get out of hand. Challenge therapy or challenging questions are advanced questions for the Department of Psychiatry. Myself as a physician, if I already know my patient has mental defect or disorder and they're borderline or they're there full-blown psychotic, the last thing I'm going to do is tell them, "I don't see those dragons." I goes, "What do you mean the government's listening to you? Government's not listening to you." "Yes, they are. I think you're a spy." I goes, "I think you're Jason Bourne," and then stabs me in the neck. All right. So be careful when you challenge your patient. Just, you're not agreeing with, don't disagree with them. Don't agree with them either. Right. Because you have to, like, for example, how I dealt with the guy who thinks the dragons are in the ceiling. "I'm sorry, Mr. So-and-so. I know you see them, but I don't see them. Can I get you to a safe place where you don't see them?" You see what I did? Now, the rest of the story is really interesting because I put him in another room so he can be in a quiet room, and I actually put a blanket over his head so he wouldn't see the dragons. Well, another nurse who didn't get the endorsement was wondering, like, why in heaven's name did Dr. Garais put another man in another room? I need this room. Let me take the blanket off. Well, he took the blanket off. She didn't read the chart. She didn't know what was going on. And what did the patient do? He goes, "No, give me my blanket back. It's protecting me against the dragons." And then she said, he goes, "I don't see any dragons. What are you, high?" And then the next thing you know, she got assaulted by the patient. Okay. And again, what do we all have to do? Leave our egos at the door. And if you follow these protocols, it'll keep you safe. Another thing you shouldn't do is probe, right? If the patient says, "I don't do drugs," even though they look like they do drugs, or they're acting like they're doing drugs, going, "Oh, don't go, oh, come on now. Nah, come on, tell me about it." Or if you have a patient who's been sexually assaulted, "Nah, you can tell me. I'm a medical professional." Do not do that. Just write on the chart that patient suggested, blah, 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 did not probe but will inform the doctor. And then it will be the doctor's or the clinician's job to dig deeper. And I also mentioned agreeing and disagreeing with your patient. Again, especially if they're psychotic, please don't challenge the patient. Every time I've been insulted or something bad happened is because I wanted to assert my dominance on my patient, which is, and if they're psychotic, no matter how tough you are, tough doesn't beat crazy. So be careful, okay? Because remember, just imagine when you're psychotic, OSIS, abnormal condition of your psyche, mind. That means that person can easily feel that their life is in danger. And imagine if you felt that your life was in danger, what would you do? You'd fight the whole world, yes? So again, be careful in probing, try not to probe, don't agree or disagree, and do not be combative or confrontational, especially with a potentially psychotic patient. Leave that to the Department of Psychiatry. Dealing with sensitive topics. Oh, do not make a diagnosis. Don't even hint at a diagnosis, because that is the physician's job or the DNP's job. That is not your job. Okay, so if they ask you, what do I have? Well, I think no. Or even saying, I think you're okay. How many times have I've told my other colleagues, if that is my patient, do not speak to my patient regarding diagnosis, because that's my job. The job of the clinician, physician, DNP, or whoever, or DO, who's in charge of that case. Okay, anxiety, depression, and again, we don't diagnose, but you should be able to recognize it when your patient is anxious. Okay, and your job is to do what? Talk them down. Your job is to make them feel a little bit better. And I think I mentioned this before. I used to love to watch Cops. For years, I just watched Cops. That and this other show, what do you call it? Cheaters, like my favorite shows. And the one thing that I always saw on Cops versus Cheaters, and Cops, if you look at a seasoned police officer, one that has their head on straight, do you see how when they go to a scene, they de-escalate everything? They don't just jump out of their car, draw their weapon, and start yelling at people. Right? A professional does what? They de-escalate all the with your anxious or your angry or even your psychotic patient. Now, depression. Okay. Remember we talked about depression, potential depression with this patient, Mr. Smith. Now, again, we're not there to diagnose, but you have to start looking at your patient holistically, or in the big picture view. Now, depression is different than bereavement and just being sad. All of us have our sad days, but depression is prolonged, and it can happen. It says here, middle-aged, often triggered by life events. Sometimes it's triggered by nothing. Depression and mental disease, a lot of it is chemical and chemistry related. Okay, so when you start noticing these things, write down the behaviors exactly as you see them. Don't make the diagnosis, I believe Mr. Smith has depression, right? You write down, oh, patient claims no sleep in the last 3 days. Patient claimed this, that, and the other thing. I goes, I noticed the patient on two occasions this afternoon within a 20-minute time period of him crying in his hands. When asked, he said he was okay. See, you only tell the truth and nothing but the truth. You don't discuss your feelings or your diagnoses. You just, as an observer, you write down as subjectively as possible what you need to write down. Okay, someone's having issues with their internet. That's okay. Same thing with substance abuse, okay? All of this here, sleeping habits, slurred speech, or all this, Yeah, it could be substance abuse. It also could be major depressive disorder. It also could be a tumor. There's a whole bunch of things, and that's my job. That's why I went to school for 16 years, right? There's a lot of nuances, but these observations that you have, patient appeared lethargic or sullen. Patient had radical mood changes. 1 minute she was yelling, yelling at the staff, and the next minute she was crying. I noticed upon interview, the patient has slurred speech. So your role as an observer, many times I see things that the patient is trying. When I was a medical assistant, I see things that the patient was trying to hide the doctor, but didn't hide from me because thinking that, oh, I'm just a medical assistant, they're not going to notice that. But you guys are now trained, so you pay attention. Okay. Oh, regarding domestic violence and interview, you're gonna bump, especially if you're in a urban center, you're gonna bump into this a lot. Men, women, children, um, uh, punching bags of all ages. All we do is we can't say, oh, patient was a victim of this and that and the other thing. We just have to write down what we see. Burn marks on the volar surface of the 6-year-old arm, bruises, bruises on the left lower abdomen and right side of the face of my 25-year-old female patient, single mother, blah, 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 right? Just as exactly as you see it. Now, regarding the interview of your geriatric patient, especially if they may have dementia or Alzheimer's, again, you have to take that interview. You have to take that interview with a grain of salt, okay? Because they could be doing what they could be saying may not be reality. And remember the definition of dementia. Again, that is also a emotional and chemical issue. Many times, my stage 1 Alzheimer patient, they know something's wrong. And it'll affect them. Okay. When you're documenting, right, be sure to note and know the 6 C's of charting. We already talked about the client's words. The chief complaint should be in the client's words, and your history should be in your client's words. Clarity. That's why we do mirroring and all that and clarification, because you must be clear on what you're saying. And if you use medical terminology, make sure it is the correct medical terminology, but not in the format of diagnosis, in the format of your role as an observer. Okay? Completeness, it should be complete, and we're going to talk about pain in a moment and the 5 things that we look at when we're looking at pain. Chronological order, it should be in reverse. Your history of present illness should be in reverse chronological order. We already talked about that. Now, confidentiality, HIPAA, HIPAA, that's the Health Information Portability and Accountability Act of 1996. HIPAA laws protect the confidentiality of our patient. And remember, the chart does not belong to the patient. The chart doesn't belong to you. It doesn't belong to the doctor. It belongs to the facility. So in order for the patient to get a copy or anyone else to get a copy, they must requisition it. And it must be specific on what they requisition. For example, if you have a court order, the court order can't say the entire chart. The court order has to state summary and blah, 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 blah. But there have been a couple of times that I've seen the whole entire chart brought physically to the court for whatever medical legal reason. That's what the judge wanted in their written subpoena. So, but typically, if you're in medical law and ethics, you'll learn that cops can't just come in and just demand the chart. My first year as a medical assistant, two NYPD detectives came in and like, oh, we want the chart of so-and-so and so-and-so. And I'm young, I'm scared of cops, especially New York City cops. I gave it up. I got into so much trouble because they don't have the right to do that. They have to have a subpoena, a court order, and the court order must be specific. And if something like that happens, you inform your chain of command immediately. You inform the office manager, you inform the doctor, and then you ask what their advice was. Me, I just got bullied and then just gave the officers complete copy of the chart. and I got into a lot of trouble for that. I remember that to this very day. Here's an example of an electronic medical record. And in real life, there's like multiple tabs for multiple things. Regarding lab reports, be able to look at a lab report and know what's abnormal. Now, not all the time the lab has these pretty little colors like red and blue. For red means it's too much, blue will be too little. Both a deficiency or an overabundance of your lab report. Those are things that have to be reported because they're outside the reference range. And I just check real quick. Oh, 252. Oh, yep, it's definitely high. 240. Oh, that's definitely high. And I inform either verbally or if you still have a paper chart, I take the actual lab report and I print it out and I stick it out of the chart just enough so that the doctor can see the patient name on the top and it's within the patient's chart. And that's another example of preempting your physician on knowing what they need. And in time, you know, when you work in an office or even in another facility other than an office setting, you'll see that there's things that you can do that will save time. And that's one way, knowing when you have abnormals, that your patient and your doctor would love to know this. So what I do is have the lab report stick out, and sometimes I put the patient phone number on a little sticky next to the lab report, because something like this I think the patient should know about. They have hypercholesterolemia, hypertriglyceridemia, and also LDLs are bad as well. And if the patient's on medication, they might not need to adjust it. So I'm definitely telling Dr. Buckwalter about this, and I'm going to flag this. Now, if you're in an electronic medical record, there's ways to flag reports and to send direct emails to Dr. Buckwalter on what's going on, so that Dr. Buckwalter then could put notes in the EMR, then could flag me, the medical assistant or medical secretary. Hey, give John Miller a call. Tell him exactly what's what. And nowadays they can do that as well. They have my physicians have this patient portal where the physician has even a little recorded message. Let's say this is mine. Dr. Buckwalter would call me and go, "Hey Nelson, yeah, this is Dr. Buckwalter. Please give me a call back. We got to talk about your cholesterol, triglycerides, and your LDLs. Not very good. I think we're gonna have to up your meds. Okay. Please call the secretary on a good time to schedule a time we can talk." And that's nowadays how they do these virtual meetings, which is really neat because you can charge for that. Here's another example. This is a BMP, or a basic metabolic profile. And it's like metabolic. You start thinking about all the chemicals in your body that have to do with processes. And the number one always is glucose. Sometimes this is called an SMA or a SMAC. So you might see it as SMA or SMAC. And if you see something like SMA 12 or an SMA 7, that means there are 7 tests. And the 7th test is glucose. If it's an SMA 12, that means there are 11 tests located in that particular metabolic profile. And the 11th test is glucose. Subjective, objective data, already went over that. Here's a nice little SOAP reminder here. And you could see these are objective data. These are all the signs. This is the subjective data. This is the symptoms. How's my patient feeling? Diagnosis, right, coming from the physician. And the plan. What are we going to do? Are we going to have any meds? Do we have to call another department? Which is your classic plan or management type items in that category. Now, here are some other things. They're nice to know. Not as common as soap, but they're still used regularly in a hospital setting. One of them is source-oriented medical records, or SOMR. Right? They categorize the chart, or they organize the chart in the way that what's coming in. What material is it? A lab? Is it an order? And that's how it gets organized. POMR is problem-oriented based or problem-based medicine. That's where we list all the problems that my patient has in from the most severe to the least. So you'll have this problem list, and let's say I have a problem list of 5 things. The most pertinent thing would be number 1. So your diagnostic and treatment plan should be numbered in the same exact manner. So I'll deal with what? The first problem, then the second problem, then the third problem. And and it helps with prioritizing what's important for our patient's management. Okay. Let us see. Chart abbreviations. You've had medical terminology. You need to know all of these and all the regular ones. But do know and understand that abbreviations, it's a double-edged sword. On one side, we use them a lot. On the other side, we abuse them a lot as well. But like I stated earlier, most electronic medical records, like if you just write like ABX, it'll have a drop-down menu of all the potential things that say ABX, right? Because A space BX means biopsy, right? And there are other places have small b, small lowercase b, lowercase x. Other places uppercase B, uppercase X. When I was practicing, it was uppercase B, lowercase x. So there's many variations, and that's the problem with medical abbreviations and why the Joint Commission doesn't like it. It doesn't like it because, you can see it's a little bit, uh, sometimes it could be potentially confusing. Pain. Remember we talked about the 6 C's of charting a minute ago, and we talked about completeness. So in order to be complete when you're talking about pain, I want you guys to think of PQRST. And it's the way that we ask the patient or interview the patient regarding pain, because that's a common thing to come into the office with, right? Like, oh, doc, I don't feel good. I got a pain in my left side, whatever. I ask, is there anything that provoked the pain or palliated it, which made it better? Anything that made it worse or it made it better? Second question would be about quality or quantity. Quantity, how many times during the day? Quality, is it sharp or is it dull? Region, where exactly does it hurt? Did it stay there or did the pain radiate or move around? Severity scale. We're going to show you a picture in a moment about the severity scale of 1 to 10, and maybe you've seen it. It's got like happy face at 1 and a very angry, sad face at 10. And remember, this is pain is highly subjective, especially to our female patients who've had children. Our female patients who have children can handle massive amounts of pain. That's why they'll underplay pain all the time. Like, yeah, it's all right, I could deal with it. When mommy says that to me, or when a mommy says that to me, I start paying attention a little bit, because they've been through the worst pain in their life, so it doesn't mean much. Now, for male patients, on the other hand, like myself, I'm a big crybaby. I will always exaggerate my pain. I'm like, oh, doc, that's a 7. When in reality, it's around a 3. But, when I get hurt, I get really babyish. And so beware of that the severity scale is highly subjective. Now, timing, right, which relates to quality and quantity. When did it happen? In the morning, before eating, after eating, at night? Did it happen while you're doing something strenuous, or did the pain happen when you were sitting down? So that's the timing. And this altogether is the complete way to do a history if my patient has pain. Know these other abbreviations. Polypharmacy, that's really dangerous. Even with EMR, it's so easy to mess up. And EMR is electronic medical records. Polypharmacy is typical for our more geriatric patients, our older patients, especially above the age of 45. It is not uncommon to find somebody with 11, 12, 13 medications that aren't updated. What I usually tell my patients, just bring it in a brown paper bag and come in and we look at it, and then I write it all down, and then we document it. Here's your health history form. And remember we stated earlier that your questions should be open-ended. Whoa, I had to yawn. Sorry about that. So questions should be open-ended. You should let the patient speak. The only time you have yes or no is when you go through this thing called your ROS, or review of systems. I wish there was a way to turn this upside down. Do I? Is this? No, let's play. Yeah. Well, you get my meaning. When you've seen this before, probably at the doctor's office. And it's like a checklist. So the way I would ask it is, Mr. Smith, I'm going to ask you a whole set of questions. And for all these questions, I don't need for you to elaborate. I just need for you to answer yes or no. Okay, so we're going to start. Mr. Smith, have you ever had any chills? Well, sometimes when I get a fever. Mr. Smith, yes or no, please, so we can get through this long list. Do you have any chills? Yes or no? No. Depression? No. Dizziness? Yes. Fainting? Yes. And if they say sometimes, click yes, or mark down yes. Now, what's the ROS, or the review of systems? The review of systems is just in case anything we missed, and also there could be a comorbidity or something that's not directly related to the main pathology that's lurking around. Like, for example, like even though my patient came in for depression, there might also be heart disease involved. And I wouldn't know if I didn't have a review of symptoms that kind of hinted to me that something's up. Here's another pretty table regarding PQRST. Oh, it's nice. I should have did it that way instead of my way. We talked about the chief complaint, history of present illness, past medical history, right? Very important, but that's usually the foggiest and the haziest part. There have been patients who had surgery like 6 months ago, and they failed to remember. They failed to mention it. It's like, oh yeah, I had surgery like in March, and are you kidding me? Family history. If you take a look at that thing, that sideways thing, you'll notice that it only asks about current family that's directly related to you. Okay, so that's mommy, daddy, brother, and sister. We don't need to know about anybody else. Okay, not even grandma, grandpa, right? Because we're looking at a potential for any genetic disorders. Here's that thing I was telling you about. That sad face, right? And you could see also it's in they have the Spanish versions as well. But you could see on a scale of 10, worst pain imaginable. Now, if mommy already had a child, worst pain imaginable, it's now going to downplay every other pain that she'll have for the rest of her life. This is really neat to have on your electronic medical records, or even in your paper chart. It's good to have your medication flow sheet, so you know when the refills are, dates, amounts, and times, and also your preferred pharmacist. All of that nowadays is electronic, and it's really neat. Okay, we're at the end of the chapter, so look at these procedures in the back, read through them, especially read through these rationale parts. I love making questions out of these, because why do you want to do something? And knowing the rationale will keep you understanding that, oh, I have to do this protocol because now I know why I need to do it. Okay, progress notes, nice to know. Medical history, we kind of talked about that. And for those of you who missed this lecture for whatever reason, let me just look at who is here today. And I know Ms. Pooh, but whoever this Galaxy S20 Ultra G, I think I know who it is. But just in the
it's me, Mr. Dr. Garais, just to make a wall.
Oh, okay. So I'll remember, right? You know, when you're in classes that are bigger, always check in and just tell your professor. So you guys don't have to do what I'm about to say because you guys were in the lecture. But for the other half of the class where some of them were working and whatnot, go on page 486, answer these 10 questions, email them to me, and you will get credit for today's lesson. But everybody that was right here, all you guys get credit automatically. But if you want to do these as well, they're nice. And it's nice because look, they match up to learning objectives, which is pretty neat. A pretty straightforward way to do. Now, let's see, what else do we have to do today? Chapter 36, chapter 37, which is vital signs and measurement. So I'm gonna look over that real quick. But a lot of this vital signs and stuff like that, first right off the bat, memorize your normals for an adult. I'm going to show you that in a minute. Go over this case. Look at this case. What is the subjective, objective, assessment, plan? Also, what is the chief complaint? Okay, looky here. My heart is beating too fast. So I can't say it's anxiety disorder. I can't say it's tachycardia. I can't say it's Mr. Mohammed here. He's a 13-year-old kid. He's on drugs, right? You can't just. I have to say chief complaint is quote, my heart is beating too fast, and the history of present illness is um, from when he started first feeling that till current. Okay, so look at that. I could also have this case as well. I could put it up. Looky here. He's on albuterol. That means he has a past medical history. Odds are it's, oh, there it is. It's asthma. And who is the attending? Dr. Williams. All right. And he's allergic to pet dander, which is like hair or any other dust from pets. So, what do you need to know in chapter 37? You need to know, uh, you need to know the generalities regarding vital signs regarding by age. As you can see here, the younger they are, the faster their pulse rate is, and the younger they are, they're also the faster their respiration. But the younger they are, their blood pressure is in the basement. It's very, very low. Know the different temperature ranges and the no, nowadays we don't do rectal axillaries only if my patient is being uncooperative. But for the children, tympanic is the preferred method because nowadays this textbook, these numbers are a little bit old, but nowadays the modern tympanic thermometer is just as accurate as the oral. But the oral ones are nice, but it's the very fact that I have to stick it in your mouth, and that's a point source of infection. It's also me getting close to your face, so there's a whole bunch of dangers there. So um, we prefer doing the tympanic, and also for not geriatric, for pediatric, it's quick. It takes 1 second. You don't need to know how to do this conversions yet, but for future reference, especially those of you who are thinking about going into nursing, there's stuff like this all over nursing. So, you could take a look at it. But nowadays, many times the thermometer, you just press a button and it'll convert it for you. Now, the temporal scanner, there's mixed reviews about the temporal scanner. Uh, like the other day in the gym, they almost didn't let me in the gym because it looked like I may have a low grade fever. I didn't have a fever. I had a hat on. I I was driving in a hot car and I was running with my kids, so of course it's going to be high. These are the least accurate. These disposable ones, the ones that maybe you see, at health centers and even at the airport. The one that just sticks on your forehead, the one that the airport have, is next to useless. But the two methods of choice is oral and axillary. And again, we try not to do rectal and all those other things. Now, pulse. It could be tachycardia or bradycardia. The range you need to know is 60 to 100 beats per minute. Less than 60, bradycardia. Greater than 100, tachycardia. Normal cardiac, or what they call eucardia, if you remember your medical terminology, that's anywhere from 60 to 100. Another thing that you need to know about pulses is that they have what they call character. So this is the rate, your pulse rate, but this down here is the character. It's a little bit more advanced than what you would put on a typical vital signs, but it's nice to know. So of course, if it's thready, like a thread, you barely can feel it, that's weak. That's 1+. But if it's bounding, like the person's been running away from a pit bull for the last minute or so, you can even see it pulsing in their neck, and or even see their shirt move on their chest. So that's 4+, and that's bounding. And those are actual terms: bounding, thready. Thready is another word for weak. Pulse oximetry. Your textbook says, I remember the discrepancy with the textbook, but for me, it's 97%. The pulse oximetry should be 97% or greater. If it isn't, that means the carrying capacity of my red blood cells to carry oxygen is of issue. And this is the pulse oximeter, it fits on your finger right there. Know this picture? Where do you find pulses? You find them at arteries. Arteries are deep, and we'll show you some tips and strategies on how to quickly identify pulses even in your most obese patient. There's a way to do it, and it's anatomy based. So of course, your temporal, carotid artery, brachial artery. Oh, by the way, don't massage this area. Okay, carotid massage is dangerous. It's the reason why also sleeper holds are dangerous. Sleeper holds, or in MMA, if you're a fan, of course, everyone's going to watch the fight tomorrow. Khabib's going to win, of course, right? You massage that area too much, and that's actually what you do in a rear naked choke. You kind of wrenching this area right here. This is where your main baroreceptor for your blood pressure is, and you could cause a lot of issues. And that's what makes your patient pass out and faint, because it bottoms out your blood pressure, because your carotid artery and your carotid bodies here will sense that, oh, my blood pressure is too high because everything's squeezing down on this poor man's neck. And so it will give a negative feedback to your blood pressure, and then it'll bottom out your blood pressure. We do carotid massage for emergency cases where the labetalol, or the medication that the emergency antihypertensive medication that we're giving isn't working. Your brachial artery, al, pertaining to your brachium, radial, pertaining to your radial bone, which is right here. Femoral, of course, your femur, your thigh bone. Popliteal, I always remember the back of my knee. I pop my knee, I always remember that way. Posterior tibial, right, which is behind your ankle. And your dorsalis pedis, that's the dorsum of your foot, and that's right there on top of your foot, okay? And we look at different pulses for different things, especially in our older geriatric patients. We are looking to see if there's any congruence, or does the left and right side match? That's what we're looking at. Here's a pulse oximeter. Look at that, right? SpO2 means the partial pressure of oxygen in my capillaries, and his or hers, I don't know, because if this is a female patient, it looks like she has man hands. So that's 98, which is good. Anything greater than 97 is good. He's not tachycardic. He's at 66 beats per minute. So he's pretty good. And these are the small battery powered ones. They're pretty neat. Because if it's under 97%, or it says here like 95 to 100. Me, I like 97 and up. I had pneumonia and I had 96 once. Okay, so it goes to show you. And also, if your patient bottoms out 1%, even from like 98 to 97 or 97 to 96, your patient will be symptomatic. Okay, and that's pulse oximetry. Respiration, right? Dyspnea, tachypnea, and it's what, 12 to 20 for an adult, it's 12 to 20 breaths per minute. And dyspnea is any difficult or painful breathing or any extra noise. Growls, this is not pronounced rails, it's pronounced growls. That's when you hear like crackling or gurgling sound. It kind of sounds like crunching up newspaper. Ronchi is you ever hear like people who, like, when they cough, they bark like a seal, like honk, honk, like that. That's what ronchi is. Hyperventilation is, of course, greater than 20 breaths per minute. Hypoventilation is lesser than 12. Blood pressure, we're going to go in lab a little bit better, but this you need to know. The blood pressure classifications. According to the American Heart Association, this is still good. Okay? So you need to, so all intents and purposes, 120 over 80 is good for your patient. But you have to take that with a grain of salt, because let's say, for example, my niece, she's what, 4'10", 95 pounds, maybe, if she's eating Doritos. She's tiny. Her blood pressure is 90 over 60, like a child, and she's in her 30s. Now, the thing is, when she got pregnant and she ballooned to a whole 103 pounds, right, her blood pressure went to 110 over 80. Now, for her, 110 over 80 is hypertensive, right? So it's different for different people, and it has to be within context. But for exam purposes and for your typical patient, it's 120 over 80. And remember, 120 is the systolic, or the heart during pumping or during at work, and diastolic is at the heart, the pressures of the heart in millimeters of mercury, but we don't write millimeters of mercury, we just write the top number and the bottom number, right? Is the when the heart is filling with blood. Kind of, you could say it's like resting in a way. And the difference between the two, like if my patient is 120 over 80, that's 40 millimeters of mercury, that is your pulse pressure, okay? We're going to talk more about in the laboratory how to read your sphygmomanometer. Say that 8 times fast. Hypertension versus hypotension. We're going to start looking at how do you calibrate, but all intents and purposes, calibration of your typical aneroid sphig or BP cuff. The arrow, when deflated, when the cuff is deflated, should be pointing down to a little box here. If it deviates right or left outside of that box, that means that particular BP cuff, also known as your sphygmomanometer, is not calibrated. Do not use it. Here's one of the electronic ones. Electronic ones are good, but they got to be calibrated every once in a while. They can be as wrong as plus or minus 10 millimeters of mercury. But typically, the modern ones are pretty good. Here's your stethoscope. Know the parts of the stethoscope. This looks like a lovely picture I could put on an exam. Could I just wipe this all out and just say A, B, C, D, E, F, G? Yep. And of course, we'll be going over this in laboratory in much greater detail. The palpatory method, that identifies your systolic or your upper end. And then the auscultatory method is both systolic and diastolic. And we're going to talk about those particular sounds and what to look for, okay? Orthostatic or postural hypertension. Be careful when you take blood pressure, especially of an older patient, or especially of a patient that has some sort of either hypertension or hypotension, because if they get up too fast, the heart has to fight against gravity, and blood doesn't get to where it needs to get to in the brain fast enough, and you could have the patient go through syncope or faint. So having them get up way too fast is not a good idea. And we do things like this here. We do or what they call an orthostatic trial, where we have the patient lie down, take their blood pressure, heart rate, have them sit up, blood pressure and heart rate. Then in a couple of minutes, sitting again, and then standing up. Okay, and then if there's any associated symptoms like dizziness, or they felt nauseous. Okay, now heights and weights, mensuration. Um, we don't use the body mass index or BMI as much as we did 20 years ago, but BMI is just one of the many ways that we can look to see if the person is in healthy, overweight, or obese. And the formula is for BMI is, I forgot, it's the weight in kilograms times over the height in centimeters. Let's look how to calculate BMI. And also you could calculate BMI. Here's a BMI calculator. How's BMI calculated? It is the weight in kilograms divided by the height in meters squared. And oh, here it is, right here, right? The mass of my patient, which is in kilograms, and the height, which is meters squared. Okay, and that's your BMI. So if we look at this, it gives us a score. And depending on where you are in your height, it'll point to the optimal body mass index. And people who like, I'm 5'4", and in order to be healthy, I should be under, oh heavens to Murgatroyd, under 140 pounds. Are you kidding me? I'm a good what, 205, 206. So I am now what, class 1 obese. There are different classifications of obesity with class 3, was it 4? I can't remember the numbers, but that's grand or morbid obesity, and that's trouble. Okay. But BMI is exaggerated because most people are in the overweight category or borderline obese category according to BMI. And that's also kind of the reason why we don't use that anymore here in the United States. We do, but there are other things that we also look at. And one of those things is we measure also, there are other formulas and there are other things that we can measure. And another thing I'm going to also show you in laboratory are the calipers, when they had those little pinchy things that, why am I speaking crazy? Let me show you. Here's those calipers, and they pinch and they have a number here. And based on that number, right, like, this, oh, look at this guy, right? Oh, this guy's all ripped, barely probably has 5% body fat, maybe 4, right? And by the way, ladies, you're supposed to have 20% body fat. You have estrogen. But is a really healthy guy, but it's a very unrealistic way to look but this is combined with a whole bunch of other things. And these things are called calipers. Yeah, there's more my speed. There you go. Look at that. That's nice. Okay, so look at the procedures in the back of chapter 37. They're nice, and we're definitely going to do these procedures. We're in lab because the first lab is all about this particular chapter. But the focus for you for this chapter is know your normal values. Okay, so what's due next week? Homework 2, right? You could take that picture, or you can get one online of history, and just do one with a family member, right? Another thing that somebody else did, they did it in front of their phone or camera, and they sent it to me that way as well. That was a neat idea, but not all of us have all that technology. But take some of these history forms, and you can find them online, or you could use the one in your textbook. And again, take your history of your family member, and so you can see all the parts of the history taking, and how to take it. Don't forget, there's a quiz 1 that I put up. Try to do that by next week. Definitely do quiz 2 by next week. Here's another extra video that we have on top. It's an older lecture. And of course, discussion 2. Let's look at discussion 2. Okay, read the article and answer the question. Do you think that the United States has similar problems regarding this video? And then kindly cite your sources via APA 7th edition format and at least 200 to 250 words, but please no more than like 800 words. That's a lot for me to read, because you think about it, you multiply it by all of you, and be concise, and that definitely is due next week. All right, it's at this portion of the show. I didn't see anything during the lecture. Does anyone have any questions regarding this lecture, or what is due, or what do they have to do? You could unmute yourself, or you could put it in the chat box. But if you have no questions, have a nice day. Happy weekend. And I'll see you next week, and you could log off. But if you have questions, kindly either unmute yourself or post it here in the chat box. Hello? Anybody have, Miss Roxana, do you have a question? I see you are on.
Can you hear me?
Yes, I can hear you.
Yes. So for the week for one.
Yeah.
So for week one, you mentioned that we're supposed to define the two words, right? The crazy ones. But I didn't know what the other part. I didn't know what you meant when you said drugs. Do that means that I have to find the kind of drugs that cure that specific disorder?
For discussion one?
No, for that part two of the homework one.
Oh, part two. Define MRSA and VRSA, right? What does MRSA and VRSA means? So define the drug of choice. Like, so if my patient has MRSA, what drug do I give them? Because if my patient has MRSA, typically I give methicillin for Staphylococcus aureus. So what medication do I give if my patient can't have methicillin? And if my patient has VRSA, vancomycin resistant Staphylococcus aureus, what do I give instead of vanco? What is the drug of choice?
And to look for the kind of drug that I eventually or potentially use for that patient, where would I
just Google
look?
it. How would I do it? I would do this, drug of choice, MRSA. And it would say vancomycin continues to be the drug of choice for MRSA. And if vanco doesn't work, my patient then has VRSA, right? And then of course you quote wherever you got it from, right? I could have got it from here, .gov. Here's another. Now, what's the drug of choice for VRSA?
Because I was searching medicine or eventually drug for VRSA, and it was just giving me a lot of crazy stuff.
Right
so
here. Right? It's linelazid. Still linelazid. It's been linelazid for forever, which by the way, VRSA is so common now.
Okay.
When I was practicing, VRSA is scary. Nowadays, it's like, it's called Tuesday. That's how bad drug-resistant strains are. But yeah, you could see how if you like Google things like real simple, like drug of choice VRSA, like don't put too many words, it'll give you what you want. Okay, and then all you have to do is like, boop, I got that, right? That's where I got it from, right? And sometimes if you get lucky like this, you see my screen?
Yes.
You click on citation here, and well, there it is. And I just take it. You can take this and copy and paste it. Boom, done. All right, so make sure you get that in today.
Can I
get that in today.
Fix it and resubmit it?
Yep, just
all right, thank you.
Just put it back in. And me, I'm cool with, like, if let's say you get something on time, but it's like not your best, you know, just tell me like, hey, Dr. Garais, I found something better. Yeah, give it to me. So instead of the 80, I'll give you the 100, right? The initial has to be on time.
Okay.
So that's my thing. All right. Anybody else? Anybody else? Miss Hassan? Miss Hassan, are you still there? So if you have no other questions, kindly log off so I know. Oh, there's somebody. Oh, here's the questions. I defined it, but did not put a drug down, and I forgot to quote. Yeah, so just put it in. Just put it in. Oh, but she probably heard me already, and she had me in another class, so she knows. So if nobody has anything, kindly log off so I know that. I should stop recording.